Morning, Megan. We already have people in the waiting room.
All right. Good morning.
Good morning.
Good morning.
Good morning, Megan.
Oh, good. I want to make sure somebody can hear me. Thank you, Amanda. Okay. Good morning and welcome to our 2021 GIS Day. Oh, there we go. Yes. Please put all of your good morning cheers in the chat, pictures of your coffee mug if you would like. I really appreciate all of you being here today. My name is Megan Compton. I'm our State Geographic Information Officer. And for the last 3.5 years, I have had the pleasure of working with and learning from many of you. The least of which are certainly not those on our GIO team, who I'd like to introduce to you. Many of you know Amanda O'Daniel. She's our GIO coordinator. Sean Scholler, who's our GIS program manager, and Irvin Goldblatt, our GIS technical manager. So you'll hear from some of them this week and also watch them kind of behind the scenes making a lot of things happen. But I have the wonderful opportunity to get to work with that team. So we missed you all for GIS Day in 2020, but we are very excited for this event and the technology that continues to enable us in this virtual environment. This event would not happen if it were not for the direction and management of Amanda O'Daniel. This year, Amanda led a team that moved us ahead and brought you this great content that you're about to listen to today and tomorrow morning. The projects in 2020 and in 2021 were certainly impacted by the pandemic, but they didn't stop. It was amazing. The great projects are examples of the collaboration and coordination from many leaders in our state GIS community. Projects like the Lake Michigan Coastal Program and New Coastal Atlas, the State Data Harvest collection of framework data layers, new license and permit tools for Hoosiers, the first year of our next statewide aerial imagery project, field applications and surveys that help meet people where they are instead of flooding them with complex technology. And also new ways that we are using GIS to improve transportation safety. These are just some of the things that have happened in the last 2 years since we've seen each other. And these are projects that will move forward, many of which you'll hear about over the next couple of days. I want to take a minute and also thank you and appreciate the planning committee for this event. First, I would like to start with Annalise O'Daniel, who is the artist of our GIS Day logo. And you'll see that on our splash screen here and all through all of the materials. So extremely talented and appreciate all of her hard work and dedication to helping that happen. I want to thank Leah Harmon. She is such a rock star and helped us with many of the technologies behind the scenes that help make our registration so much more simple this year. Other room monitors and committee members, Roger Colpine, Robert Gottlieb, Joel Bump, Diane Osborne, Ashley Moore, Caleb Slocum, Myra McShane, Jeff Motes, Joanna Wood, Sean Scholler, and Irv Goldblatt. Thank you all, and I appreciate the time and effort that you've put in to make this day a success. As we know, this year looks a little different. We mentioned that. There isn't a learning lab that we usually have in the back corner of the near the auditorium, nor do we have a vendor area. But there are 16 amazing presentations over the next 2 days, including the one you are about to hear. And just a note for how to use Teams for this event, a little bit of housekeeping for you. You will join each presentation individually by either using the link provided in your email and calendar invite or by visiting our website, in.gov/GIS, and then navigate to the GIS Day link and join each individual meeting. In case you miss a presentation or two are side by side that you want to hear one of them and you can only go to one, don't worry about it. We are recording all the presentations and we'll be posting them to our website. We'll let you know when those are ready for you. Additionally, you will notice that each of you are muted. If you have a question that you would like to ask our presenter, please utilize the chat and we will ask on your behalf. Thank you again for joining us, and we all look forward to being in person next year. It is now my pleasure to introduce our 2021 GIS Day keynote speaker, Dr. Lindsay Weaver. Dr. Weaver is the Chief Medical Officer for the Indiana Department of Health. She joined the Department of Health in 2020, February of 2020, and she brings to the role a passion for both emergency medicine and end-of-life care. Dr. Weaver is an assistant professor of clinical emergency medicine at Indiana University School of Medicine and practices emergency medicine at Methodist Hospital in Indianapolis. Wow. She is board certified in both emergency medicine and hospice and palliative care. She earned her undergraduate degree in biology from the University of Kentucky and graduated from University of Louisville School of Medicine. She received residency training in emergency medicine and fellowship training in hospice and palliative medicine at IU School of Medicine. And she completed a fellowship in ethics at the Charles Warren Fairbanks Center, Medical Ethics at Indiana University Health. She has served as quality director for the Department of Emergency Medicine and physician lead for the System Sepsis Steering Committee at IU Health. She also served as executive director for the Indiana Patient Preference Coalition and as president of the Indiana chapter of American College of Emergency Medicine Physicians. Dr. Weaver and her husband have 5 daughters. A little bit about the presentation you're about to hear. The Indiana Department of Health has been working, as many of you know, on COVID-19 response since early 2020. This presentation will highlight all of the ways that IDOH uses GIS as part of that effort. This includes maps, web applications, geoprocessing, and statistical analysis of case, test, and vaccination data, testing and vaccination sites, logistics support, and social vulnerability. These examples are used both to inform the public and help with internal decision-making. And without any more pause, I'd like to welcome Dr. Weaver.
Good morning, everybody. I am so grateful to be here and that I was asked to be your keynote speaker this morning. So as mentioned, my name is Lindsay Weaver. I am actually wearing my scrubs today. I will be working in the emergency department later today. Feel it's still important to continue practicing. So that bio was my pre-pandemic bio. I actually started this job about a month before we had our first case of COVID, and I've been all in COVID since that time. I am a map enthusiast. I have been my entire life, pre-Waze and Google Maps. I was a kid sitting in the front seat, with my dad with the big paper map spread out and, pretending like I was helping him navigate, even though he had been to whatever place we were going a million times, but always have been a visual learner and fascinated by maps. So my team will even tell you that when we would be in a planning phase for anything, and I'm going to go through some of those, but honestly, we use GIS and mapping so much, there's no way we could show you all of it. So we're just highlighting some of those things here today. So my team would know that when we're planning something that I was going to want a map. So immediately be like, don't worry, we're working on a map for you. And that is honestly how we would make a lot of our decisions. So I'm really excited to be able to show you the amazing work that my team did throughout this last year. So, sorry. Okay. So since March of 2020, we've had over 1 million cases of COVID in Indiana. Nearly 15 million tests were done, nearly 17,000 deaths. We had a peak hospital census of 3,400 in November 30th of 2020, and had over 7 million vaccine doses administered. The amount of work and effort that has occurred, not only from the Department of Health, but from hospitals, clinicians, volunteers, local health departments, pharmacies, everybody who's been involved in this process has been quite tremendous. Our GIS team is part of the Office of Data Analytics, which was created in the fall of 2020. Before that, GIS, informatics, and data analysis were in the ERC. Currently, the Indiana Department of Health GIS team is Robert Gottlieb, who is on here today, and will help answer any technical questions if they come up. If you have questions, by the way, while I'm speaking, go ahead and put them in the chat. I'll be monitoring it and try to answer them as I go along. If not, I left plenty of room at the end of the presentation to answer questions. So GIS team is Robert Gottlieb, who is the GIS coordinator, and Gary Rayner. Chris Waldron was the GIS coordinator until September of 2021. So most of these visuals were created created by these three that will be presented, but they build off the work done by many, many more people: surveillance team, informatics, preparedness, and those who collect test samples, and of course the team of leaders and decision makers. So most of the applications that you will see use AGOL. They can create applications for public or internal use. We put aggregated stats on AGOL, not patient information. We have many AGOL users who are not full-time GIS staff, also make use of other visualization tools such as Tableau and open source tools. Many of these GIS projects use scripting and automation, and main scripting languages used at IDOH are SAS, Python, and R. Most processes run daily or weekly, especially useful for data processing, geocoding, and generating statistics. And so I will tell you, I'm not an expert in all those things. I just know what I want. And so I'm very happy to be able to go to my team and say, hey, I need to see this. And they do all that stuff I just talked about in the background and put together some of these wonderful visualizations and interactive tools that the public also interacts with, not just the IDOH team. So I want to take you back to, oh, I'm sorry, it says 2021. That's wrong. It's actually 2020. So February of 2020. And this is back when we were hearing about the coronavirus on the news. You know, it was something that was in China. We were stopping the cruise ships from being able to unload people on the coast. We had stopped flights. But really, it was a sense that we were going to be able to, you know, contain it and that it somehow prevent it from getting into the United States. We were almost on daily phone calls every day with, you know, our federal partners and the CDC, learning as much as they could learn or knew about this new virus. And on February 25th of 2020, not 2021, we were on a phone call with the CDC, and this day will forever burn in my mind. You know how sometimes there's just moments in your life where you knew kind of everything was going to change. And the CDC director at that time, Nancy Messonnier, said, ultimately, we expect we will see community spread in this country. It's not so much a question of if this will happen anymore, but rather more a question of exactly when this will happen and how many people in this country will have severe illness. It still gives me chills to read that quote out loud because I remember her clearly saying that. And I was listening to that phone call in a room with several people before we were doing all the social distancing. And I jumped up, and we ran out of the room, and we're like, we've got to start planning. We need to get out of this, you know, this mode that maybe the virus will never come here, and start planning. So that was on February 25th. And then on March 6th, we had our first case here in Indiana. If you can remember back then too, testing was very difficult to come by. So we were using the CDC's testing, and so we had very limited supplies. We had people collecting tests from across the state and actually were sending it to the Department of Health, and we were forwarding those tests to the CDC for them to test at first until we had the ability to actually do the testing in our lab. So, you know, we went from not having tests to be able to test for this to having to send every test to the CDC to being able to test, you know, a very limited amount in our lab. And it took a significant amount of time to, by the end of April, trying to get testing across the entire state and testing sites across the entire state. So here is one of the first maps we looked at when we were planning for where can we strategically place the testing sites, right? And you'll notice that we have the roadmap on here as well. The other important thing about this is that we were still having to transport tests into Indianapolis where we were actually able to run those tests. So the Department of Health and Eli Lilly was our testing partner at that time as well. A couple other labs, all based in Indianapolis. So we, you know, there's a timing issue there to make sure that we can get tests quickly in order so we can get those results. And back then it was taking several days. We partnered with the Indiana National Guard throughout this entire process. And so here again is an example where we actually use their armories as testing sites. And we used their armories for testing sites for quite a long time. So we went from that, you saw those very few testing locations to this, our testing site map. That is interactive. It is on our public website, coronavirus.in.gov, where people can go and find a testing location near them. They can search by their county. You know, you can scroll in. If you hover over the pin, it'll tell you, what is the exact location, what are their hours. The other important thing that this did for us is for some time we were testing locations, we're limiting who they were testing. If you guys remember that back then too. And so it would also tell you who they were or were not testing. Some sites weren't testing kids, some people were testing just symptomatic patients. So it was able to give people a lot of information. We also included in there links so you could link to go sign up to get tested, or a phone number if people were making appointments. New sites are added all the time. So the Department of Health has 10 mobile units that drive around the entire state to do testing, and they also do vaccines simultaneously. And so they'll come into, a rural community or even, urban communities that don't have good access to testing or vaccines, and they'll be there for 3 days. So this is a constantly changing map. So by geocoding the addresses of people who were tested for COVID, whether they were positive, negative, and those who are vaccinated, we can examine COVID patterns in more spatial detail. So this is a map of positivity on a grid from July 2020. And we've become much more sophisticated since then in displaying our positivity maps. But so from July of 2020, brighter red shows a higher positivity rate for the time period selected. So just an example of the many, many maps that we use. So I was talking to you about those mobile units. So speaking of the mobile units, we also in order to pick locations that we need to go, we look at what is the positivity, and what is the vaccine uptake, and then we look at our map and say, okay, how many testing sites are around there, and that we need to clearly go there and get some testing done. Specifically this fall, we are really paying attention to school age cases, so kids between the age of 5 and 18, and their number of cases rising, because we wanted so desperately to keep kids in school this fall, and we have been very successful across the state of Indiana. And part of that solution was my team saying, we're going to go to where we're having a rise in cases in kids, so that we can make sure that there's plenty of testing there. So this is a map of change in test density from July of 2020. Red means there were more tests in an area recently, and blue means that there were fewer tests. So another really, we found some very interesting patterns across throughout this pandemic. Essentially, we'll see a rise in testing first. So we'll start to see that number of tests needed start to go up in a community, followed by a week to 2 weeks later in a rise in cases, followed a week to 2 weeks later, rise in hospitalizations, followed a week to 2 weeks later, a rise in deaths. And we have seen that pattern over and over and over again. And it follows the same thing on a peak. We actually know that we're near our peak, not because we start to see our cases fall, but actually because we see our number of tests start to fall in a given area. I think the other thing too to keep in mind is that, while our recent surges have seemed to be pretty much statewide, in the beginning they were very regional. So we really had to use the maps to help let us know, okay, they're having that's a hot spot down in Vanderburgh County, down by Evansville, right? Or there's a hot spot down in Clark County by Louisville, and then therefore, that's when we would get on the phone with the hospitals down there, the clinicians down there, the local health department leaders, and say, hey, we're seeing you guys start to rise in cases. What can we do to help? What are you doing to prepare? We also geocoded addresses and used to supplement reporting on long-term care facilities and jails. So if a county has a high percentage of its cases from long-term care facilities or jails during a week, the county is actually flagged on our public dashboard to acknowledge this is a congregate setting outbreak and not necessarily, a hot spot in the entire county. And so the long-term care case counts are also used in a Tableau dashboard for internal review. So lots of different uses. And Zoom could zoom into these different populations. Just like congregate settings, we also pay really close attention to universities. When they were doing a ton of testing last year, that really changed the positivity count and the number of tests in a community. So we couldn't really depend on, for like where IU is and Purdue is, on just those things to see whether or not it was currently having a hot spot. So that was kind of, brought you through, pre-vaccine. And then it brings you to December of 2020, where we were in full planning mode for vaccine. So I will tell you that was a crazy time from, probably end of November through probably April or May, where we knew that we would be getting life-saving vaccines, right? After we had suffered so much, there was a little bit of light at the end of the tunnel. We knew that there would be significant demand for these vaccines, and that we would have very little supply. We put together an entire team of experts from across the entire state, infectious disease, immunology experts, long-term care representation, other hospital representation, ethicists, minority stakeholders, to help us decide, who would we focus on starting the vaccines in? What would our rollout be for allocating these, very precious, honestly, priceless vaccines for Indiana? We also knew that these vaccines were different, right? They had to be in the ultra cold freezers. I'm sure you guys remember all the discussion about that, you couldn't just like plop down into a pharmacy at first, and that they'd be coming in these humongous amounts of 1,000 doses at a time. So not something that you could put in a provider office either. And so we started with the plan of sending them directly to the hospitals, as most states did, but we really centralized it with our centralized scheduling system. We looked at the population. So this map is showing you, this is really one of the first maps that we use to do our vaccine planning. So you're getting to see a little bit of behind the scenes. And like I said, but this was with the input of everybody. So basically of the whole population of Indiana, you see for every county, what percent that county makes up of the entire population of Indiana, right? So I'm just going to zoom in there into the middle. Well, if you can just kind of take a look, I'm going to try this laser pointer here thing. So right in there, that kind of beige color. So you see that Marion County is 21% of all the population in Indiana, and Morgan County is 1% of the population. So we knew we'd be sending about 22% of the vaccine into that community. The H's are the hospitals that we were going to send vaccine to. So when we're talking to the hospitals, we would let them know, hey, you're going to be responsible for all the healthcare workers in these two counties. And then we also set up our system so that if you lived in one of those two counties, you'd be directed to go get your vaccine at those two locations. So we made sure that we matched the population to the area, to the amount of vaccine that was sent, and the ability to schedule. So then to kind of show you down here, right, where you get a little bit smaller populations, same thing. We directed everybody in Jackson and Jennings and Decatur to go to, I think that's Columbus Regional there in Bartholomew. And then just expanded from there, honestly. So when we moved on to the local health departments in early January, we developed the same type of maps, made sure that we had good geographic spread across the entire state, and that we were distributing by population. So there's that little bit of a zoom in too for you. And so we went from that, I think it's like 40 to 50 sites to our vaccine map. As of late October, about 700 testing sites, 1,100 vaccine sites in the state. And we have increased the number of vaccine sites with their 5 to 11-year-olds. So a lot of our primary care providers and pediatricians are now offering vaccine out of their offices. And so the number of sites has increased. It's honestly just really quite remarkable. Again, this is on our website, ourshot.in.gov. People can interact with it. They can see our mobile site. So you can see our, our mobile sites up here. Click down, because like I said, those tend to move around, or all vaccine sites, look by county, zoom in, look at the times, and figure out what is best. Oh, the other thing that here you go, is the zoom in. Location, here's how you register. Are they taking walk-in appointments? You can also see on the right here that vaccine type. So if you want Moderna, or maybe you're getting your booster and you got Moderna the first time around, you want a Moderna booster, you can look for sites that offer Moderna, Pfizer, Johnson & Johnson, multiple vaccine sites. So we try to make it as interactive as possible. You can, people also, our 211 staff, so, anybody can also sign up to get a vaccine or find out where a vaccine location is by calling 211, and our 211 staff also use this. So we wanted to make sure it was really easy for them to be able to find locations to help out Hoosiers as well. So our testing and vaccine site maps have both been viewed about 8 million times. So here it is just in a single county. Just another example, and that was my team's idea. So we've been up the track to vaccinate quite a bit. Thankful that that has been a popular place for Hoosiers to go get vaccinated. We're still out there. If you need your booster, or you have a 5 to 11-year-old that needs to get vaccinated, or if you need testing, and they put this super cute little flag on there as well. So as much, visual management as possible. So there were a lot of emails back and forth with our Office of Public Affairs to make the changes, but they recently used Experience to create a table that the Office of Public Affairs can securely edit themselves. So it has reduced the number of emails back and forth between our GIS team, between the Office of Public Affairs, where the Office of Public Affairs can now make edits to text like name and hours, etc. But the GIS team is still responsible for adding new points. They use Python script to add larger numbers of news sites. So here's an example of that Experience table for editing. So I know that the teams were really happy that they were able to work together because, like I said, constantly changing. And again, our two websites are shot.in.gov's vaccine, and the coronavirus.in.gov is our testing. So when COVID cases first appeared in Indiana in March 2020, they quickly created a public ADOH dashboard, and that version, of course, has been replaced by the current ones that you saw with a few weeks later, but had 27 million views in that short amount of time. And data was openly available for use by other applications. So vaccine equity. So I told you a little bit how we wanted to make sure that we are sending out vaccine by population and by geographic location to make sure that people had good access to it. After we received more vaccine, throughout the entire process, but really after we, had got into the flow of getting vaccine, we wanted to make sure that, or look at to see how equitable the distribution of vaccine is. So here is a map of zip code of vaccine uptake, and I'll get into some more detail exactly about how we have used this information. We are still making maps, so this is a super new map since we have started vaccinating 5 to 11-year-olds, and so this is as of last week where we're at with just with numbers in per 100,000 of vaccine administered to our 5 to 11-year-olds. So one of the factors that we looked at were social determinants of health. So, we know that where you live influences health outcomes. So we wanted to look at community level data and combine the social determinants of health with case data to improve health equity and decision making in our response. We did that with testing. So we directed our testing sites where we knew that there was a high social vulnerability index, which is an index developed by the CDC to assess vulnerability. And then, of course, we also did that with vaccines. And then we've looked at, worked with local partners to make custom indices, and I'll show you some examples of that. So just a little bit more information about social vulnerability index. It looks at your socioeconomic status, household composition, disability, minority status and language, housing type, and transportation. So here is a map that highlights some vulnerable areas in Indiana. And this looks at SVI by zip code. So we could geocode case and test data by patient address to calculate case rates and vaccination rates. And these rates can be overlaid with SVI and existing site locations to further inform our decision making. The CDC calculates SVI at the state and county and tract level. However, we were interested in also looking at the zip codes, and that's what you can see here. We use detailed population estimates to calculate a population weighted average of the SVI at the zip code level. So in this one, the more vulnerable zip codes are in the darker shades of blue. So as I mentioned, we could take, we know where the high SVI areas are, and then we can overlay that with our vaccine rate. So ArcGIS Online makes it easy to show two variables at once, and this is called Bivariate Mapping. This map compares vaccination rates to social vulnerability index. The bright orange zip codes have a low vaccination rate, but a high social vulnerability. And these are the areas that we knew that we needed more attention to increase vaccination rates. So the bright blue zip codes have low social vulnerability index and high vaccine rate. So we use this map and started calling our partners across the state to say, hey, you are the vaccinating entity, you are the healthcare leader in this area. Can you help us make sure that we're getting more vaccine here? The other thing that we would do is actually we would reach out to community centers, to faith-based organizations and say, we recognize that you are in an area of high social vulnerability and low vaccine rate. We have found that people are more likely to get vaccinated if they are being encouraged by, a local leader, someone they trust, someone that, that they relate to, and that is a place convenient for them. And so we have done many efforts to go out and, do vaccine clinics in the church parking lot or at a local fair, really whatever it took to get vaccine into the community. So in working with those partners, this is an example of where we actually worked with IU to help, zoom in and say, okay, where are the major areas where we need to focus in getting vaccine? Is there a vaccine clinic there? Are there partners that we can partner with to get vaccine information there? So they also use this information. I'm going to tell you a quick story, a tale of two cities. It's actually a tale of two counties. So if you look down here in this bottom corner are two counties, Ohio and Switzerland. Ohio is the little bitty one here, and Switzerland is this one here. So they border, there are border counties, border with Kentucky, and they got a lot of attention, not just here in Indiana, but also nationally, because in the originally, months and months and months ago, Ohio County, that little teeny tiny one, had a really high vaccine rate. I mean, they were outpacing many of our other high vaccine rate counties in central Indiana. In poor Switzerland, this little one right here had a much lower, and you can see here too, orange being lower vaccine uptake, a much lower vaccine uptake rate. And it was pretty stark. I mean, if you looked at the map, and I wish I would have taken screenshots way back then, there was a huge discrepancy. And so the question is what's going on there? So the local leaders in Ohio County, the county that had the high vaccine rate, were being praised for all the work they were doing. And they absolutely were doing a lot of work. They were, going above and beyond, going to the local diner and talking to people about getting vaccines, calling people, it's a small county, everybody knows everybody, to increase their vaccine rate. And then the health officer that was in Switzerland County with the lower vaccine rate, he was getting a lot of heat for having such low vaccine uptake. Well, in further investigation, we actually found out that our vaccine program, that is same program that is used by over 40 other states across the country, actually doesn't use geocoding. So what it did is if it looking at the zip code, it would assign the county based on how much of that zip code actually was in the county. So if when the zip code crosses the county line, if the majority of that zip code is in one county, even though the person actually lived in the other county, it was assigning to that other county. So we figured out that this actually affected every single county across the entire state. But when you look at really small counties like these, and you can see all these zip codes that are here that are overcrossing, that it really made a difference down there. And since counties were comparing against one county to another county on their vaccine rates, we actually did go back, geocode that, make sure that all of our addresses were getting assigned to the county where the person actually lived, and updated all of our counties. So we had a phone call with Ohio County giving them the bad news that they still are doing remarkably well. Again, you can see they're blue and gray here, but not as well as we thought. And then also a call to Switzerland County to let them know that they weren't as bad as they originally thought. And then further, we also figured out that a lot of our Switzerland County residents had actually got vaccinated over in Kentucky. And in case you didn't know, we don't get vaccine data from every single state. We are getting it from Ohio. They use the same system that we use, but have not gotten the vaccine data from Kentucky. Just quickly, a couple other things that we used maps for was for PPE delivery. I'm sure you guys all remember how important PPE was and how short our hospitals were. So early on in the pandemic, many hospitals faced a PPE shortage, and then we were buying PPE, and also we were receiving it from the federal, caches of PPE that they had. So we were getting a lot of it in, and we needed to get it out. So we developed internal web apps to monitor delivery status of PPE to hospitals in real time. Worked closely with the emergency preparedness department to develop this, and the PPE delivery was conducted back in 2020. So this dashboard isn't being maintained, and so it shows that there's no one waiting to receive, but they were able to monitor this in real time. We use state police to help deliver the PPE. We use our department transportation to help deliver the PPE. So it was quite the production to get these, pallets and pallets and pallets of stuff out to all of the hospitals. And so wonderful that they are able, again, to use maps like this to help deliver that PPE. And so also example of the health department and hospital status here. So we've also used maps in evaluating where we possibly might need some hospital support. So I don't know if you remember the discussions where we thought maybe we'd have to set up extra hospital sites to hold patients. And so in those communications, we recognize it's not going to just be one hospital that's having trouble. It'll probably be a lot of hospitals in the area that were, over full. And so we are constantly and continue to constantly monitor maps like this about ICU availability, right? Where are we really having some trouble? The other thing, like I mentioned earlier, is that, different than our last couple waves where really the whole state kind of flared up at once, it was really regionalized. So we may see very low, ICU availability up here in Lake County, which is what we call District 1 for our preparedness districts. And so we would then work with District 2 and say, hey, District 1 is having low ICU availability. Are you guys able to take transfers in? So that would not be a normal direction that they would possibly transport patients, but we were able to use maps like this and show them, like, look, you're partnering counties, maybe not where you would typically send patients, but they have more ICU availability. Something else we're paying really close attention to is critical staffing shortages. So where do we have a low number of nursing, really is what it comes down to in the state. And you can see that there's definitely some areas that we're highly concerned about their staffing availability. So school outbreak monitoring, not all of our schools report cases to us. And so we use geocoding cases among school-age children. So again, looking from 5 to 18, and are we seeing an increase in cases in a particular county? And then we would use that information to actually do outreach to the schools. Hey, we're seeing an increase in cases there. Are you guys having an outbreak? What mitigation measures are you using? Is there anything that we can do to help? But it just would help initiate that conversation and, would help us narrow our focus to where we needed to maybe, go offer testing. So areas with statistically significant hotspots by case rate among school-age children are in the brighter shades of red here. Again, it's imperfect because many kids go to private school or alternate schools or homeschooled, but it does help us identify potential school outbreaks. And then wastewater testing, very interesting thing. So we received an FDA grant to test wastewater for a small number of sites, and this is testing wastewater for COVID. They have found this to be an early indicator of COVID increasing in the community. So again, received a grant and supplement testing at those sites. Of course, we needed to go figure out where we needed to go and test. So we wanted a large enough public sewer system with agricultural areas with local vaccine and looking at local vaccine rates as well. And they calculated vaccine rates by census designated place and also looked at locations, agricultural labor camps. So here is a map of the locations. So looking at agricultural areas was part of the grant funded by the USDA, and we spatially joined testing data to the census designated place and boundaries compared to population data to calculate vaccine rates. And then here's a map of the agricultural labor camps. And we use this criteria to identify sites that would be the most useful to test. So GIS is just one small part of the large amount of work conducted by everyone at IDOH, but it has been integral to the work that we have done. As mentioned, our surveillance team, contact tracers, the executive staff, field staff, preparedness team, immunization team, state labs, governor's office, MPH, our partner resultant, the IoT, FSSA, Regenstrief, healthcare workers, pharmacies, local health departments, school staff, CDC, National Guard, Zotec, which helps us do our scheduling for our testing and vaccines, Optum, other state partners, all work together. I mean, the list, I can go on and on and on about all the people it took to do this, honestly, and still do this, and we'll continue to do this. I'm not sure if you have noticed, but unfortunately, we are seeing an increase in cases again. This was not expected, as it's not followed a typical pattern. We would typically have, after a big peak like we just had, would go down pretty far in our case counts and our case positivity before we would start to go back up. But it's not completely out of nowhere. We actually saw the same thing occur in the United Kingdom, where they had a peak with the Delta wave, came down a little bit only to go back up again. And it seems that they have reached that second peak of the Delta wave and are back down again. So monitoring this very closely, again, working with partners, using our maps to identify the regions and the locations that are having a higher number of cases right now before the others. And then of course, working with them to plan and prepare, and we will continue to do so. So thank you all for your time. I am happy to answer questions at this time. Okay, so the first question I see is, have you seen opportunities for crowdsourcing data related to the pandemic? I guess it depends on what you mean by crowdsourcing. So if you mean crowdsourcing, like people giving us information, like, from everywhere, maybe. We haven't really done that. I will say that we do get data from everywhere. So that whole list of people that I just went through all were giving us data and for information. So we worked really, really quickly to make sure that we had all the connections that we needed in place to be able to give this information to the public. So we said from the very beginning, we are going to be profoundly transparent with the data that we were receiving. And we wanted it to be as up to date as possible. And so I really, I'm super proud of the Department of Health, because we really led nationwide, I believe. And even to this day, I encourage you all to jump on some other states' COVID sites, take a look at theirs compared to ours. I mean, not that I'm a competitive person or anything, but ours is, quite amazing. Very interactive. Some states are still just reporting total number of COVID cases, and then you'd have to do a bunch of other stuff and basically look at a spreadsheet to kind of zero in on your county, where we, are supplying that information visually. You can see the map, look at your county and say, okay, this is what our cases are, our case positivity, this is what color, warning color we are at this time. This is our vaccine rate, this is our fully vaccinated rate or partially vaccinated rate. So, lots of information, and that comes from several different sources. So we work closely with, like I mentioned, Regenstrief, also with IHI in order to receive information constantly back and forth with the hospitals, local health departments as well. I'm not sure if that answered your question, but how can the Indiana GIS community better support you? I mean, honestly, I think this is just the beginning. I was just telling my team, we've shown the world what we can do with this information, and I hope that the world wants more. Right? Why don't we have maps like this and this level of communication every season with flu, right? Flu follows the same patterns. It ebbs and flows in different areas of the state, and you might have a hot spot, right? So you can go to the IDOH website, look at the map and say, hey, you know, there's a high level of flu right now. You know, maybe I'm at risk because I'm immunocompromised in some way. Maybe for the next couple of weeks, I might lay low, right? Or make different decisions about the interactions that I have to, you know, decrease my likelihood of getting flu. You know, other infectious disease outbreaks, right? Is there an opportunity that we can use mapping to show, you know, honestly, there's an outbreak of syphilis right now down in the Vanderburgh County, Evansville area, right? And show where we can see that, and other STDs, hepatitis A, hepatitis C, HIV, you know, even RSV, so respiratory syncytial virus, right? So we can start to show where that is starting to peak. So, I mean, please let us know. We've made the connections. We're further improving this. You know, what does the public want to see? And we'd be happy to partner with any of you all in doing that as well. What data sets were the most important and which were missing in your analysis? Robert, do you have any thoughts about that?
So I'm trying to think about missing at first. Not sure. Think of anything that comes to mind really. I'm not sure the question of data sets are most important for looking at like where do we need to direct resources. I mean, when I think of like projects that are most interesting, I mean, how we work on the testing and vaccination site apps, and it's definitely the most visible thing we've done from a GIS side, most publicly visible. Beyond that, you know, I'm always interested in comparing social vulnerability with our vaccination rates. You know, I come from a background of part of how I got interested in GIS was, you know, how, you know, came from a natural hazards perspective, tornadoes, floods, that's where the social vulnerability index actually originated. So that was my background and how I got interested in these vulnerability assessments. So, I mean, that's always interesting to me. And I hope it adds an extra dimension to, you know, beyond just looking at the test numbers, the case numbers, you know, different people are going to be affected differently. It's not always an equitable effect. So I think looking at that information is also really important, you know, in addition to those case numbers.
So I think you bring up a really good point. So actually, continue to miss a large amount of race and ethnicity data. So we found out early that our EMR, so electronic medical records across the state, and not just the hospitals, but other locations as well, didn't have a way to connect any race and ethnicity data that they have collected to a test. So they could send us the test results, and you know, we know that they most likely had race and ethnicity data, but it wasn't actually connected and could send. And way back in March and April, I mean, that was one of the requirements set forth by the CDC. And then we also, you know, underscored that here in Indiana, that we had to get the race and ethnicity data on this testing so that we could pay attention to disparities, right? We have seen our Black and Hispanic populations affected more by the virus, also lower vaccine uptake. And, you know, again, in looking at social vulnerability, high social vulnerability areas as well. And yet that was not connected. And really, I mean, so that honestly shone a light on it's never connected, right? That level of information to test results, right? Whether it be COVID or any other test. And so I think that really shone a light on that. And then we figured out and worked our way around it, but still are missing, you know, in some cases as high as 30% of that level of information for people. So to me, that's kind of been a dark spot and something that we will continue to work on.
Yeah, that's a really good point, and something we look at it with other conditions as well. We see that in other conditions. So we have like groups of people who are interested in health equity and looking at that as some more specific case studies in other conditions as well, because we see that with other conditions. So it also reminds me that you know, the pandemic has been very disruptive for the Census Bureau, their data collection, the 2020 census, the American Community Survey, so that social vulnerability index is based on like American Community Survey data in large part. So, you know, it's become more difficult to collect accurate data. So all these things we talk about, like, you know, positivity rates or the like the school outbreak detection, there's always or the vaccination rates, everything's based on a population estimate. You know, we don't have the exact numbers for any of that. It's always an estimate. There's always some uncertainty there, like county level, tract level, how many people are in an area. So I mean, you can see in some areas, like in a zip code, you know, you might see like, oh, over 100% vaccination rate or very close to it. And that's because the population data is never going to be perfect. So there's always an element of uncertainty there. And it's going to become more challenging going forward with how the pandemic itself has disrupted census data collection, and how, you know, so much has changed for people. I mean, you know, look at like social vulnerability index, and that includes like percent of people unemployed, for example. Well, that really changed because of the pandemic, and it's got up and down. So the data has been, that kind of data has been more disrupted when we try to look at that.
Next question, is the easy access to home testing affecting your analysis? So lack of data. You know, we know that we are missing a lot of tests throughout the entire pandemic, or a lot of positives throughout the entire pandemic, right? So some estimates say for every positive case that you actually have accounted for because you've had a positive test, there was 3 others, right? Whether they were never got tested, right? We're just sick and stayed home, or, you know, I know lots of families where, you know, dad tested positive and then all the rest of the family is sick. And so they're like, why are we all going to go get tested, right? And so situations like that where they're, you know, almost pretty sure they have COVID, or, you know, again, these tests aren't perfect. 30% of the time it's a false negative. So they got tested, but it still wasn't a case. So, you know, it's hard to say. I think we're definitely in a position now where people's attitudes toward testing, home testing, all those things are probably starting to play a bigger role. And we really need to do what we would call our typical surveillance and pay less attention to positivity rates, right? Because that is making a lot of assumptions, right? That's making assumptions that everybody who is symptomatic is getting tested. That's making the assumption that the test is, you know, works 100% of the time. And so typically we would do more of a surveillance like we do for flu, where we pay attention to a rise in flu-like illness, right? So people with flu-like illness presenting for care. Well, we have the same thing for COVID. So COVID-like illness and a rise in them presenting for care, right? And that would kind of give you an indication, okay, we're starting to see an increase in cases in a community. Again, looking at our recent COVID-like illness surveillance data, we have seen over the last week or so an increase in people presenting to emergency departments across the state seeking care for COVID. So I think, so I guess it's a yes and no. I mean, that specifically is definitely part of probably a bigger thing, and people's, you know, desire and to go get tested. You know, a lot of people who are fully vaccinated, if they have a little bit of a runny nose and maybe a little bit of cough, they're probably not going to run out and get tested like they would have, you know, before they were vaccinated, you know, even though we still can get COVID, even if you are vaccinated, but might just have super mild symptoms. That's a long answer to your question. Got your booster at the Speedway. That's awesome. Staff there were fabulous. Use 211 for all vaccine appointments. Very easy way to go. Thank you. Take no credit for it. It's all my fabulous team. Have you tapped into any real-time temperature monitoring data, such as real-time Bluetooth digital thermometers to look for rise in outbreaks? Not to my knowledge. Robert?
We actually did talk about, so I'm on calls twice a week with resultant and MPH folks and data science modeling team. I remember we talked about this pretty early on and didn't wind up using it. This was quite a while ago. I want to say the reason was that, you know, we found some service and it just didn't seem like there was really enough data to work with there on like a community level, but this was quite a while ago. So we talked about it and it didn't go anywhere.
I will say, I mean, not really for surveillance, but in general, everybody's kind of turned away from temperature monitoring in general, just have found it to not be helpful at all in looking for COVID. So I remember there was a stat from the TSA when they were doing temperature monitoring across the entire country, and they found that it was, I mean, so minute how many people that actually, you know, popped positive for temperature, and then just doing like the, you know, the population calculations that they would be missing 95% of people with COVID going through the airports, and so they stopped doing it. Coming from a background of wastewater, is exciting to see COVID trends in local areas by testing wastewater. Kudos to Notre Dame for testing in St. Joseph. Yeah, I think really helpful for those big university towns, for sure. And we have seen that across the country as well. Any other questions?
Dr. Weaver, we have one question from a little bit earlier. How can the Indiana GIS community better support you?
I think I answered it in that, I mean, let us know what more you'd like to see, or where you can tell us where you can help to partner. Robert, do you have any thoughts about that?
Not off the top of my head. Maybe if I had some time to think on it more. I mean, we've seen other products this time that the GIO is been involved with. For example, I'll see an example later on in one of the talks about food access mapping, food distribution mapping, I believe. It's tricky because, you know, kind of our model on the GIS team is generally like, you know, we get requests usually from other people within the agency, such as Dr. Weaver, and, you know, and we go do that. Sometimes we get, you know, questions from community partners. That happens occasionally, but mostly a request comes from someone else in the health department, maybe who's working with someone in the community. There are a few examples where we've worked with other agencies as well, so other state agencies. I guess because the model is more, we take requests from others, you know, our most direct customers is our coworkers, and you know, then eventually goes to help the public. We haven't been oriented in that way of thinking outward as much, and maybe that's, you know, something we can consider more in the future. Part of it is also just the effect of having a small team. You know, with us being in the Office of Data and Analytics now, we're kind of tapping into some more ways of generating maps that aren't just, you know, ArcGIS products, you know, getting more involved in like Tableau, R mapping potential. You saw some Tableau maps this year. So we're also becoming a bit more diverse in the mapping technology we use. So that also opens it up to staff availability and more products that we can use and get more tapped into our informatics team. So, you know, that's one direction we're looking, is more diverse technology for our mapping. I don't know how well that answers the question, but that's just kind of where my mind went.
Yeah, so I will say that we are constantly trying to think of ways, for, you know, at the leadership level of, you know, what do people need to see, what do we need, and then communicating it to the team to help meet those needs. So we're actually leading a data transformation across the entire Department of Health, and this is part of that. Is like, what does the future of sharing this information for across all spectrums of public health mean for Indiana, and how can we best communicate that and be transparent with the information we do, and also that we do not have, and make sure that we're working to get that next level of information. So it is now 9 o'clock. I want to thank you all again so much for having me here. I was thrilled because I said I am a lover of maps, and I don't know what I wouldn't have done without Robert and his team in order to be able to provide this information so that we can make educated decisions on what we were doing and where we were going. You guys have a wonderful program scheduled for you. So happy GIS Day to all of you.
Dr. Weaver, thank you so much. I really enjoyed this, and I hope everybody else here did too. The upcoming presentations for today and tomorrow will be really encouraging and kind of tickle on that innovation in GIS area. We have record attendance for this year with 415 people registered. So I'm excited to see how all of the chats continue on in the sessions. And I hope to see you also at our closing presentation on Wednesday, where we'll show and discuss the next phase of spatial data integration, hosting, and management. So your next presentation starts at 9:15 a.m. We have GIS in very non-traditional ways and an opioid vulnerability assessment across Indiana. So thank you very much and have a wonderful GIS day.